one thing here. Well, that's not going to work. I'll try that. All right. Okay, so I'm going to discuss, or at least try to discuss, osteoporosis management in patients with advanced chronic kidney disease and end-stage renal disease. Well, you were right, Amir. There we go. So because I believe this is a continuing medical education accruing activity, I will state that I have no financial interest to disclose. I will not be discussing off-label indications of pharmaceutical agents, at least none that benefit me personally. As I say in all of my grand round presentations, I have done none of this work, and the many investigators who did all the studies that I will discuss deserve the credit for allowing us to derive insights from their work. So there'll be two outlines. This is a general outline, and then there'll be another one sometime in the middle of the talk. I'm going to start by discussing some bone basics, and I do mean very basic. Then osteoporosis and more, fractures, the continuity, for lack of a better word, between osteoporosis and renal osteodystrophy, diagnosis, including bone biopsy, bone biomarkers, and some novel imaging techniques, drug trials, drug therapies, and their limitations. So hopefully I am not causing nightmares of first-year medical school, but this is a very schematic approach to bone. The things that I want to point out here is this epiphyseal growth plate. So endochondral ossification, in other words, the replacement of chondrocytes by osteoid, occurs at these growth plates. At the end of puberty, these growth plates seal. The key two types of bone are the cortical and compact bone, but also very importantly, the trabecular or cancellous bone, which not only includes mineralized fibrils, but also the marrow space. And osteoporosis, both in individuals with normal renal function and with impaired renal function, can lead to bone loss, bone mineralization loss, and loss of bone quality in both the trabecular components and the cortical components. Okay? Now, we humans have a lifelong struggle to retain bone mass. Okay? This graph was from, the Journal of Pediatric Orthopedic Surgery. Okay? And we can see that in both men and women, there's peak bone mass around 20. And then with the onset of menopause, women lose bone faster as they age. Suboptimal lifestyles, which I'll discuss, such as tobacco use, alcohol use, a sedentary lifestyle, obesity, can lead to earlier onset osteoporosis, as can certain nutritional deficiencies, such as deficiencies in calcium or vitamin D. Okay? Now, to kind of learn so if I can just go back one slide, excuse me. Much of the bone biology, bone medicine world has focused itself on trying to retain as much bone mass as possible, particularly in women who have an accelerated loss of bone mass due to estrogen deficiency, and I'll discuss why that's important. Okay. Now, I think it's important to know, at least briefly, the players in this process, and we roughly know them as the osteocytes and the osteoclasts. Okay? Osteocytes are derived from mesenchymal stem cells, and through signaling processes, primarily through what's called the Wnt beta-catenin pathway, they differentiate into osteocytes, or cells that lay down bone matrix. Okay? Osteoclasts are derived from a hematopoietic stem cell lineage, and they are, at the end of their development, these giant multinucleated cells that work to break down bone. Okay? So important to just get the players right here. Now, I'm not introducing this slide primarily so that we can go over everything there is to know about bone, various bone cell formation, but rather to introduce two particularly important players in the process. Okay, actually three. I'm not going to really talk about sclerostin simply because the clinical data are really in process. And I think I'd be talking more about sort of experimental therapies rather than the real world, but instead to kind of discuss two important players in this. One is called rank and rank ligand. Rank stands for receptor activation of nuclear factor kappa B, and its ligand, called rank ligand, and osteoprotegrin. Okay. Now, rank ligand, important thing about when rank ligand binds to rank, that process will lead to a stereotypical and sort of quasi-pro-inflammatory cascade that activates osteoclasts and tells osteoclasts to do what osteoclasts do, which is use a polar vacuolar ATPase, which was partially discovered by a previous chief of this division, to break down bone. Okay? Osteoprotegrin is a decoy binder of rank. So it's sort of a competitive inhibitor of rank and kind of keeps rank ligand in its place. Okay? We can see that the Wnt beta-catenin pathway is paramount in all sorts of bone development pathways. There are drugs that are in the pipeline for interfering with the Wnt beta-catenin pathway, because a lot of times the activation of the Wnt beta-catenin pathway actually inhibits bone formation. So the inhibition of this pathway would potentially improve bone formation. But again, that's a little bit not quite ready for prime time. Okay? So we'll talk about some bone trivia here, which I found quite interesting, and that is the role of estrogen in the maintenance of bone. Okay? So estrogen directly impacts on rank ligand and prevents rank ligand from binding to rank. Okay? Whether it's by a direct process or an indirect process, I don't quite remember. But the bottom line is that estrogen, the key role of estrogen in maintaining bone maintenance is to inhibit and interrupt the binding of rank to rank ligand on these multinucleated giant cell osteoclasts. Okay? And so you can imagine with the loss of estrogen postmenopausally, it's going to be far more binding of rank ligand to rank on osteoclasts with resulting bone loss. Now, you may ask, well, guys don't have estrogen. Why don't guys lose bone mass? And that's because the testosterone produced by men through aromatase becomes estrogen. And that's why men are able to preserve bone mass a little bit later on in life. So that's my bit of bone trivia. We'll try to get on to other things. Okay. Now, all of us are internal medicine doctors. All of us have taken care of, particularly older women with osteoporosis. We've sent them for DXA scans, all that sort of stuff. And by and large, in our internal medicine years, we were looking after people who had normal renal function. Okay, and so bone density was by and large the only parameter that was important in our internal medicine world, a world of aging women, postmenopausal women, aging men, perhaps with hypogonadism. Okay. By the way, that's why when either a primary care provider or a endocrinologist or whatever evaluates a man for hypogonadism, that person will always send that patient for a bone density scan, because that's going to be one way of discovering exactly what type of, how badly the low testosterone level has affected the male. Because if there's loss of bone, that really kind of tells you that there's a loss of testosterone. But in our world, okay, in the kidney world, two things have to be looked at. Not just bone density, which, by the way, is unreliably measured in chronic kidney disease and end-stage renal disease, but also bone quality. So what's bone quality? Bone quality is things like how well collagen fibrils are cross-linked, okay? How mineralized the trabecular bone component is, or even the cortical bone component is. How well can bones absorb, for example, force of impact? Is there adequate marrow and fat composition? Okay, and so in And what we'll see going forward is that in our world, in the kidney world, bone density is only part of the factors that we have to consider in looking at why our patients get fractures, why our patients have less than ideal bone quality, for lack of a better word. Okay, and so you can see some of these, parameters here. This is a review article by Susan Ott, who is very much of a thought leader in this area. So bone strength, force of impact, bone quality, all of these things conspire together in a maladaptive way to lead to fracture. Okay. So we'll go over a couple of definitions here. So osteomalacia is the decreased mineralization of newly formed osteocyte at sites of burn turnover. Osteomalacia usually results from vitamin D deficiency, but osteomalacia also develops in chronic metabolic acidosis, which we as nephrologists see all the time. Osteopenia is low bone mass based on bone mineral density. Osteoporosis has a number of criteria, including a frailty fracture of the spine, wrist, hip, proximal humerus, or pelvis, significantly low density, or a high risk for fracture based on a fracture calculator like FRAX. DEXA, or DXA, as the bone people like to call it now, is dual energy X-ray absorptiometry, a diagnostic test that uses low-dose X-ray to measure bone mineral density. The T-score is calculated from the DEXA, either a positive or a negative number that indicates the standard deviation above or below bone density compared to the bone density of a young adult of the same gender. The Z-score is a comparison of bone density to an age and sex-matched individual. Things that I'm not going to discuss during this talk are the trabecular bone score, which is derived from the DEXA with specific software because of its unreliability in patients with chronic kidney disease. Okay? And this is a classic bone density scan, and you can see the T-scores here. Again, osteopenia connotes a T-score between -1 and -2.5. Osteoporosis is a T-score of less than 2.5. Okay, so the current screening guidelines for individuals without kidney disease include women who are 65 or older, postmenopausal women younger than 65 with a risk factor for osteoporosis. Men, tough to say, but I think it's part of the diagnostic algorithm for men who are being looked at for the management of hypogonadism. Okay. Now, bone preservation and bone loss are mediated by a number of factors. So bone preservation is basically just good health, maintain a healthy weight, avoid alcohol, avoid tobacco, calcium intake, vitamin D intake. Bone loss is precipitated by obesity or tobacco or alcohol, a sedentary lifestyle, or decreased vitamin D. That makes a lot of sense, right? And I guess that's all well and good until you look at our patients. And this is, if you go on the internet, you can find any number of descriptions of renal osteodystrophy. I wanted to pick the most painful one so that everyone could see exactly how many pathways there are. And if you would indulge me, for the applicants who are here, let's just kind of look at something very simple, right? We have a patient with decreased renal function that's going to lead to hyperphosphatemia. Hyperphosphatemia elaborates a phosphatoric agent called FGF23. Try to get rid of the phosphorus in the urine. Problem is that FGF23 also inhibits the formation of vitamin D. And if you have inhibition of vitamin D, you'll have decreased serum calcium absorption from the GI tract, and concurrently, you'll have increases in phosphorus levels, both of which lead to hyperparathyroidism. Why do we care about hyperparathyroidism? Well, there's two types of PTH secretion. There are pulsatile secretions of PTH that actually enhance bone formation. But a constitutively elevated PTH does what? It highly upregulates the mRNA of rank ligand. Okay? So as we discussed before, rank ligand, when it binds to rank, is going to turn on osteoclasts and lead to bone loss. Okay? And you can go through any part of this slide and it kind of leads back to just basic badness of bone resorption. Okay? So clearly, the problem of bone and mineral disease generally, renal osteodystrophy specifically, and osteoporosis specifically, become far more complicated in the people in whom we look after. And unfortunately, the tools we have to evaluate for these diseases really fall short in a number of ways. And I'm going to try and discuss some of that as we go forward. Okay. Now, KDIGO, the Kidney Disease Improving Global Outcomes Consortium, has tried to reconfigure our understanding of both, specifically of renal osteodystrophy. And I think certainly when I was a fellow, renal osteodystrophy, I would almost describe as a two-dimensional entity. Well, was the phosphorus high? Was the PTH high? Was the calcium low? Are we giving vitamin D? Are we giving a phosphate binder? All that kind of stuff. It was, I dare say, very much of a laboratory. Well, sorry about that. I just clicked on something bad. It was very much of a laboratory exercise and a drug dispensing exercise to make the laboratories look better. Okay, but now, and I think legitimately, mineral and bone disease encompasses really, has become, I think, more of a systemic disease that encompasses not only laboratory abnormalities, but bone abnormalities, but also vascular calcification with a impinging or perhaps impacting cardiovascular survival in patients with chronic kidney disease and end-stage renal disease. Okay. Now, what we can do in terms of cardiovascular disease and things like that, I think that's important, right? I think it's some cardiovascular health in our patients with chronic kidney disease and end-stage renal disease. You know, cardiovascular disease kills a lot of our patients. But, you know, we really are in the world of bone disease and fractures, okay? And these are two very famous slides, one from Sharon Moe, one from Glenn Chertow's group, first showing that the incidence per 1,000 patient years of hip fractures increases significantly as the renal function falls, okay? And that the mortality of patients, of individuals who suffer hip fractures, increases significantly with both CKD and end-stage renal disease. Okay? Not included on this slide is a separate analysis that was done by this group that shows that the financial costs of hip fractures in patients with chronic kidney disease and end-stage renal disease far outstrips on a patient-per-patient basis the cost of managing hip fractures in patients with normal renal function. Okay, so we've now set ourselves a task, multiple tasks, to try to figure out how best we can manage these multiplicity of bone diseases in our patients with CKD. Okay, so we're almost, I would say, a little bit more than halfway through on this, and so I'm going to put up some mid-discussion topics. Okay. So the paradigm for renal osteodystrophy has changed somewhat into what we call the turnover mineralization volume paradigm. We need to treat the osteodystrophy, but there's more to it. Okay? There are limitations to our screening, imaging, and diagnosis. They are mostly unreliable, but I think there are more new modalities on the way. We can discuss bone biomarkers, which may or may not be ready for prime time. There are therapies for osteoporosis, as all of you well know, but therapies for our patients come with pitfalls and potentials for great harm. And then I'll try and discuss some future directions. Okay. So this is what's called the TMV classification of renal osteodystrophy. Okay. Turnover, mineralization, and volume. Let's move this here. And this is from a review article. Actually, it should be in Kidney International. Forgot to put the journal here, but it's in Kidney International in 2006. And you can see that various bone diseases in chronic kidney disease have been categorized in different ways. So, for example, osteomalacia, okay, has low turnover, but also decreased mineralization. Okay? Adynamic bone disease Again, low bone turnover, okay, but also low bone volume. Okay, so these people, we have to do what we can do to try to increase the bone volume. Okay, mixed uremic osteodystrophy usually has high turnover, but can have any number of bone volume and mineralization. Similarly, osteoitis fibrosa, the scale of bone volume can go from low to high, okay? But usually it's a high turnover disease. Okay? And so if we could find a way to identify low turnover, modest turnover, high turnover, and if we could find a way to accurately diagnose osteoporosis in our patients, we would be able to provide some sort of integrated bone therapy. Okay? Those are difficult tasks to accomplish. Okay? So we're going to come back to the TMV classification a little bit later in the talk. Okay? So we have to treat the osteodystrophy, okay? Because we now appreciate renal osteodystrophy as a part of or a spectrum of a multi-system disease. Okay? Now, we have to do our best to normalize the calcium. We have to do our best to reduce the phosphorus level. We have to do our best to achieve PTH levels within KDIGO guidelines or what have you. Okay? Whether FGF23 is truly pathogenic or an epiphenomenon, really a marker of disease, I think you can get a couple of hundred nephrologists in the room at ASN and discuss it, and probably there'll be no one alive coming out of that room, given the great emotion of which FGF23 is debated. But certainly the regular aspects of renal osteodystrophy you have to treat. Okay, but what we may be falling down on ever so slightly is this part of the equation. You know, what are we doing about the intrinsic bone disease? You know, the bone disease of decreased turnover or decreased mineralization or high turnover. Okay, so this is the part of the equation that we have yet to solve. Okay, so conventional screening and diagnosis for osteoporosis and chronic kidney disease and end-stage renal disease lack accuracy or efficacy. I have crammed together a lot of summary statements from a fair number of references to make this slide. Probably a little bit intellectually dishonest of me. I'm happy to give the references to anyone who would like. Okay, but I'll continue for now. So DEXA scans accurately measure bone density in individuals without kidney disease. But as we have discussed, they measure only density and not quality. Okay? And DEXA scans are unreliable in patients with vascular calcification disease, which shows up a lot in our folks. The augmentation of DEXA data with a fracture tool prediction tool like FRAX has not increased the fidelity of DEXA scans in patients with kidney disease. A derivative of the DEXA scan, what's called the trabecular bone score, has been introduced to approximate bone microstructure, but the trabecular bone score measures microstructure in only 2 dimensions and has not been shown to be very additive regarding the predictive value of the DEXA scan. Okay. So what do we have that perhaps might help us? Okay. Well, there is a new imaging procedure, relatively new imaging procedure called high-resolution peripheral quantitative CT, or HRPQ-CT. And its adherents like to call it the virtual bone biopsy, which gives me a good segue to discuss bone biopsies. So, of course, double-label tetracycline bone biopsy is the gold standard to diagnose any type of renal osteodystrophy. 1 minute, please. Unfortunately, fewer and fewer practitioners know how to do a bone biopsy, and fewer pathologists know how to interpret one. Okay? So HRPQ-CT uses a low radiation dose to assess in 3 dimensions bone morphometrics and density at peripheral sites, such as the radius and the tibia. And newer software has allowed for compartment-specific cortical and trabecular evaluation of bone structural and mechanical properties. Okay. So this was sort of a cool proof of principle type of study. that was published in a somewhat obscure journal, Bone Reports 2022. But I can tell you that people are building upon this particular, that people are building on this study. So they took, this is from Brazil, they took approximately 20 hemodialysis patients and did simultaneous bone biopsies and this special CT scan. Okay, so with the bone biopsy, you know exactly what you're looking at, right? You know what the cortical thickness is, the trabecular bone volume, mineralization, whether it's low turnover, whether it's high turnover. You know everything with the bone biopsy. Okay, and with HRP QCT, using these very sophisticated imaging techniques, you can get this really good look at trabecular bone, both from the radius and from the tibia, as well as cortical bone from the radius and tibia. A number of these calculations can also be made just from this imaging study, okay? And so they were able to compare their calculations of cortical thickness, trabecular bone volume, trabecular thickness, all this other stuff from their imaging procedure with what they saw in the bone biopsy, okay? And try to figure out whether the measurements they got from the CT scan could somehow be matched up with the measurements that they got from the bone biopsy to look at either low turnover, normal turnover, or high turnover bone pathology, along with just plain bone volume, okay? And I will tell you that receiver operator curves did not match up particularly well. There were some things that were better than others, okay? But a number of people have started to take this particular technique and really go with it, okay? There was just a paper published very recently from Tom Nicholas, who is at WashU, looking at sort of repeated measure assays of patients with chronic kidney disease and end-stage renal disease using this procedure to look at bone turnover, okay? And I think it may be a very promising modality for doing that definition of what we need in the TMB classification. In other words, what is the turnover rate of bone? Is it low? Is it high? Is it in the middle? And if so, then what's the bone density? What's the bone quality? And how can we put all that together to figure out how best to treat bone disease in our patients? So this particular technique is restricted. I think that both the hardware and software is not widely available. But I do think that perhaps it's something promising in the future, because it is non-invasive. And as I said, a lot of people call it the virtual bone biopsy. Okay. Okay. So we can then move on to biomarkers. Okay. And there are a number of biomarkers, circulating biomarkers of bone disease. Okay. And I've listed some here. Serum amino-terminal cross-linking telepeptide of collagen 1, carboxy-terminal cross-linking peptide, carboxy-terminal cross-linking telepeptide, on and on and on, and serum tartrate-resistant acid phosphatase. So these are some markers of bone reabsorption. We also have some markers of bone formation, such as osteocalcin, sclerostin, osteoprotegrin, alkaline phosphatase, bone-specific alkaline phosphatase, which will turn out to be very important, and certain types of collagen. Okay? As you can see, a number of these have renal, including hemodialysis clearance. So their reliability is somewhat suspect, okay? And this particular biomarker, serum tartrate-resistant acid phosphatase, is completely unavailable as a clinical test. It is a research test, but completely unavailable as a clinical test, okay? Well, we do have bone-specific alkaline phosphatase, and we do have PTH, okay? Now, in a paper that I can't show because the way the data was presented was just difficult to kind of abstract, Stuart Sprague published in 2016 a sort of correlative study to look at, to try and define turnover status of bone using a combination of bone-specific alkaline phosphatase and PTH, and was able to achieve some pretty good fidelity in figuring out in defining different turnover types using those two biomarkers. It's not really been carried forward particularly well, okay? There was a fairly large study that was done in Europe where a number of patients, either with stage 4, stage 5 CKD, or kidney transplantation had bone biopsies and measurement of a number of bone markers. Okay? The population is very heterogeneous. Why they threw this population together like this, I'm not really sure. But because they had the bone biopsy, they could again determine not just bone mass, bone density, but also bone turnover. Okay, and they tried to correlate those particular findings on the bone biopsy with their bone markers, and with some moderate success. I think the specificity, sensitivity, and positive predictive value were not particularly good. Okay, but the negative predictive value, okay, which is the likelihood that the person with a negative test does not have the disease, was actually fairly high. So it is kind of a good sort of exclusive or excluding mechanism using some of these markers. And I think the ones that are available to us, unfortunately, are only going to be bone-specific alkaline phosphatase and PTH. Okay, so we kind of have to use those in combination to sort of figure out what type of turnover status there is. Again, I am not aware. I mean, it's certainly easy to order alkaline phosphatase isozymes, right? We do that all the time. So we should be able to get bone-specific alkaline phosphatase from our own labs, and we certainly get PTH from our labs. Whether we can somehow get more of these bone biomarkers available to us for clinical study, and whether they will, in the end, be helpful to us in defining turnover status, it remains difficult to say right now. Okay? So I want to go back to the TMV classification. Okay? And I think we've known for years that not all renal osteodystrophy is the same. Okay? And I think that our treatments have done some good. Okay? I've been doing this for a long time, and I really can't remember that many patients of mine, going back from my fellowship to my time here at University of Florida, who died from a spine fracture or hip fracture or things like that. I'm sure it's happened, but it's not the kind of thing that has happened all the time. But with 500,000 hemodialysis patients and a number of PD patients and even patients with transplant, these bone diseases are going to remain predominant in our lives. Okay? And with new imaging, new markers, and medications, we might be able to precisely treat renal osteodystrophy and osteoporosis. So, for example, okay, if we have someone with adynamic bone disease, okay, with low bone mass and low turnover, a bisphosphonate might not be the best idea. It's not going to add bone mass, okay, and bone mass requires an element of turnover, or growing bone mass requires an element of turnover to succeed. Okay? So perhaps a bisphosphonate might not be the best medication for these people. Perhaps an anabolic medication like teriparatide might be better. Okay? So using this algorithm, or using the TMB classification, perhaps we can, with added data, try and figure out which medications are going to be the best for which patients. Okay? Now, these are the number of pharmacologic fraction prevention therapies that are available. Okay? We know about oral bisphosphonates, act on direct osteoclast inhibition. Okay? We know about the complications of these things, such as esophagitis, osteonecrosis, all this other stuff. Last year, when I was visiting my parents, my mom had an injection, had a zoledronic acid infusion, and boy, that was a tough one. She the side effects that were described here were certainly as advertised. Okay, so we have direct osteoclast inhibition of bisphosphonates. Okay? We talked about the rank ligand inhibitor, also reduces osteoclast differentiation and activity due to inhibition of rank ligand. Okay? Major side effect is hypocalcemia. Selective estrogen receptor modulators like raloxifene, okay? Like all estrogen replacement, there's a risk of venous thromboembolism, stroke, or cardiovascular disease. And then you have the anabolic agents, parathyroid hormone analogs, okay, which have to be administered for a very long time. Okay? And stimulation of the parathyroid hormone receptor increases bone remodeling, but it's given in such a way that formation is greater than resorption. Okay? And this new medication here, romosozumab, the sclerostin inhibitor, I'm not gonna discuss. Okay. So other things that I'm not going to discuss: nutritional vitamin D therapy. Okay. I would say that polite but nearly strident debates continue between our community and the endocrinology community about the role of nutritional vitamin D. Now, the endocrinologists correctly point out that there is some alpha hydroxylation of vitamin D precursors outside of the kidney. But a study done by a nephrologist, a post-hoc analysis of a major vitamin D supplementation trial called VITAL, did not demonstrate a decrease in fracture rate among patients with low-grade CKD who received vitamin D therapy, and I've given the reference there. Okay. Selective estrogen receptor modulators, or SERMs. Okay. SERMs have certainly been shown to increase bone density. Within the nephrology community, I don't think SERMs have ever really been part of any bone or mineral metabolism algorithm, perhaps because of the excess risks of thromboembolism and major adverse cardiovascular events. Calcimimetics. Okay? The EVOLVE trial was published in 2012 and demonstrated no beneficial effect of cinacalcet as a medication to prevent fractures in ESRD patients. Okay? And I think this was a great disappointment to many people. Okay? So Sharon Moe and her colleagues reanalyzed the data in 2016. They found a number of non-random allocation errors. Patients who received cinacalcet were older than the ones who received placebo. And when they reconfigured all the data, they came up with an approximately 16% decrease in fracture rate in patients with end-stage renal disease who received calcimimetic therapy, which I guess is good. But I think all of us, maybe not all of us, but I certainly use calcimimetics primarily to treat hyperparathyroidism with little consideration of its effects as a fracture prevention medication. Okay. All right. So what about bisphosphonates in individuals with chronic kidney disease? Okay. So this was a study of oral bisphosphonate therapy, a cohort of two large databases. And it was a data analysis of renal function in patients with stage 3B to stage 5 chronic kidney disease. And this is 1- survival curve, or I guess you could say, a death curve, meaning those people that used bisphosphonates lost renal function faster than those who did not. Now, as has been pointed out to me by my friend Dr. Canales, the numbers start to go down fairly dramatically as the years go by. But this particular study, retrospective though it was, put a lot of panic in a lot of people, okay? And sort of reading over some of the review articles by the real thought leaders in this field, like Thomas Nicholas and Simon Shu and people like that, their reticence to use bisphosphonate therapy in individuals with stage 3B to stage 5 chronic kidney disease for osteoporosis management has increased significantly. Ironically, they also say that bisphosphonate therapy, because you can't lose any more renal function, might be appropriate in certain cases for individuals with high turnover disease who have end-stage renal disease. Okay? But right now, bisphosphonate therapy seems to be taking a bit of a hit among practitioners who treat bone disease in patients with CKD. Okay. So what about rank L inhibitors, or denosumab? So I will discuss a post-hoc analysis of the FREEDOM trial. The FREEDOM trial, or the fracture reduction evaluation of denosumab in osteoporosis every 6-month trial, was published in 2009. You can see a large number of women were enrolled, split between denosumab and placebo, and it was a fabulously successful study. Denosumab significantly decreased fracture rate when compared to placebo. Okay? So Jamal et al. Reviewed the fracture risk and bone density among enrolled patients with CKD. Now, the renal function was calculated by Cockcroft-Gault. So take that for what it's worth. You also have to take for what it's worth the fact that study of denosumab in patients with chronic kidney disease and osteoporosis may be limited because there's now a black box warning for denosumab in patients with an eGFR less than 30 mLs per minute because of hypocalcemia. Now, be that as it may, we can see that among patients with stage 3 chronic kidney disease, the rate of vertebral fractures was decreased with denosumab therapy. Okay? Not so much non-vertebral, okay, but certainly vertebral fractures was decreased. And the lumbar or the bone, the T-score improved because there was a small but significant increase in bone density across all classes. Okay? So denosumab as a treatment for osteoporosis, as a means of fracture prevention, as a means of increasing, as a means of increasing bone density, may be very appropriate for our patients with stage 3, even advanced stage 3, perhaps early stage 4 chronic kidney disease. Okay? What about anabolic agents such as teriparatide, which is a PTH analog? Sorry, I misspelled that. I'll fix that. So teriparatide, a PTH analog. This was a small study that was done in Japan, published in a somewhat obscure journal, Osteoporosis International, that showed kind of differing effects. Okay? This was monthly teriparatide at a dose of 56 milligrams. We can see that the lumbar spine bone mineral density increased with teriparatide, but it certainly did not increase in the femoral neck or in the proximal or in the distal third of the radius. Okay? Now, I will say, and I've not included this in the talk, that a number of other investigators have started to use teriparatide using different doses, some of them even daily, as we probably should be doing, rather than monthly teriparatide. And those investigators, some of the results are still unpublished, those investigators have shown increases in bone density in the radius and in the femoral neck, along with the lumbar spine. So in our patients with end-stage renal disease who have low bone mass or adynamic disease, this anabolic drug might yet be an important adjunct to therapy or even primary therapy in some of our patients. Yeah. So I think this is a reasonable paradigm. I'm going to conclude around now. I think this is a reasonable paradigm for the management of some bone and mineral disease, including osteoporosis in patients with chronic kidney disease or end-stage renal disease. Okay, so GFR less than 60, of course, lifestyle interventions, of course, treat the osteodystrophy, treat the osteodystrophy. We have discussed that DEXA scanning may or may not be particularly reliable in this patient cohort, and maybe one day we'll have HRP-QCT instead of DEXA once it's been well validated. But if we sort of continue along the path of the DEXA score, we either look at the T-score, plus or minus fracture, try to assess bone turnover, perhaps with bone-specific alkaline phosphatase, perhaps with a combination of bone-specific alkaline phosphatase and PTH. If we can identify high turnover, we would use an anti-resorptive agent. Okay? If we were to identify low turnover, okay, we could use an anabolic agent like teriparatide. Somewhere in the middle, I guess we're forced to do a bone biopsy. But again, perhaps one day, this particular technique, HRP-QCT, or the virtual bone biopsy, will substitute for an actual bone biopsy. All right, so I'm going to conclude by saying that patients with chronic kidney disease-associated osteoporosis, when present with pre-existing renal osteodystrophy, have an increased rate of fracture with an increased morbidity. I think it is fair to say that individuals with stage 1 to 3 chronic kidney disease can be screened and treated according to general population guidelines. Imaging techniques beyond DEXA are needed to evaluate bone disease in stages 4 and 5 CKD and end-stage renal disease. Perhaps the combination of biomarkers with newer imaging techniques will allow for an accurate assessment of TMB status. Undoubtedly, newer medications do increase bone mass and reduce fracture risk, but their uses in chronic kidney disease patients and end-stage renal disease patients requires, as with all medications, weighing risks and benefits, and bone turnover and bone mass may become important factors in determining which medication to use. And so I'll end there, and I hope the applicants had a good day. And I think we have a couple of minutes for questions. Hopefully I can answer them.
Yeah, Joe, that was absolutely fabulous. Thank you. That was great. I have a couple of questions, but I will limit mine if other people have questions to ask. The first question is in the TMV classification scheme that you showed. Do you have is it known the prevalence in each of those buckets as CKD progresses?
Sorry, Mark, could you say the last thing again?
Is a prevalence in each of those buckets, the purple, the blue, the yellow, etc., as CKD progresses, what's the prevalence in the general population of CKD patients?
I don't have a good answer to that. I will say that it is somehow, let me put it this way. I think that the diagnosis of some of these TMV status, I think almost entirely depends on measuring the PTH and the phosphorus, right? And they'll basically say, oh, this patient has CKD4 and they have a PTH of 50, so they must have adynamic bone disease, you know, or they have a PTH of 600 and a phosphorus of 9, so they must have, you know, high turnover disease. So I think it's a little bit difficult for me to answer that question. I think, again, going back to, I think the lack of real great imaging and even a prospective cohort going forward who would get some of these repeated measure assays. That's why that one paper that I talked about, the new fancy CT scan with Tom Nicholas, who is now running some sort of bone center at WashU, doing these serial measurements of bone turnover using the high resolution peripheral quantitative CT, I think is going to be, would be a great help.
Yeah, I agree. The other thing, you mentioned the biomarkers, and what I always understood is when you have a situation where the bone alkaline phosphatase is high and the PTH is high, you know what you're dealing with.
Yes,
when they're
absolutely.
both low, you know what they're dealing with.
Right.
Anything else, all bet, or you're more likely dealing with something, but anything else, all bets is off. Is that your understanding as well?
Sure. Yeah, and I think that was the. Hopefully, no one's getting a seizure from my moving these slides so fast. But I think that was sort of the point that that Dr. Nicholas and his colleague made here, right? Between the lower limit of normal and the median of the reference range, even if you add PTH, this is where you're going to have to do the bone biopsy. But again, maybe I'm putting too much hope in this HRPQCT modality. I'll admit to that. But you know, our ability to do invasive procedures has just become so limited that we have to look for something else. You know, I will say, you know, this particular marker here, the serum tartrate resistant acid phosphatase, which is a marker of bone resorption, if this became clinically available and we could combine this, a marker of bone resorption, with bone-specific alkaline phosphatase, a marker of bone formation, we'd be able to sort of look at things from two different directions.
Right.
I'm not exactly sure what the holdup is in getting TRAP5B approved.
Interesting. And then I guess the one last question is, you talked about the unreliability of DEXA. Is that a lack of sensitivity, specificity? Will you miss osteoporosis, or does it falsely call osteoporosis?
I think it's the other way around. I think when they talk about vascular calcification, I suspect there's probably a lot more calcification in the small blood vessels of the bone.
Okay.
That might be saying, oh, look at all this calcium, the bone density must be good.
Okay. So if you got osteoporosis on a DEXA scan, it's reliable in that sense.
Yeah, I suppose it is. But you know, I think it still doesn't tell you about the turnover status. One thing.
Correct. Yes.
And again, I think it really only tells you about density. And I think individuals with normal renal function, I think there's the assumption that quality is preserved. Okay, that bone quality is preserved. That it's just the density that's low. Well, we can fix that. Okay. But in CKD and end-stage renal disease, I think the paradigm is shifting towards not only is the density possibly low, but the quality is low as well.
Right.
So how do we, and that's something that DEXA can't detect.
Well, thank you again. That was great.
Thank you, Mark.
Dr. Jog, I have just two questions. So first of all, I feel like the FGF23 kind of like a culprit for driving a lot of component of osteoporosis. Would you say that if we have any antagonistic effect of FGF23, would that able to kind of like control the whole driving factor of osteoporosis or this whole cycle?
I don't know if I would go that far, only because at least
Okay.
in my interpretation right now, and I certainly involve other people who are more knowledgeable than me, I think there is still really a raging debate as to what FGF23 is. In other words, we know that it inhibits vitamin D formation. We know that it does a lot of these other things, but at the end of the day, does FGF23 really cause disease? I mean, I remember Miles Wolff presenting these beautiful pictures of rodent hearts with, high dose FGF23, and they all develop left ventricular hypertrophy and all this sort of stuff. And, I mean, I'll defer to Dr. Kazari and Dr. Hatimzadeh. I don't think there's any, like real great data regarding FGF23 levels or FGF23 inhibition and preservation of cardiac function. And so whether this is really a marker or whether it's really pathogenic is just beyond its inhibition of 1-alpha hydroxylase. I don't know what I'll say I don't know what it is.
Okay. And the second follow-up question is like, as we all know, like the CKD and ESRD, the most common cause of mortality is cardiovascular diseases. And I think like one of the inciting factor is vascular calcification, which could be kind of like secondary to hyperphosphatemia. Do you think like if we are able to control the hyperphosphatemia, which is the driving force of vascular calcification, would that able to control the early coronary atherosclerosis in this patient? And would that kind of like help in the cardiovascular mortality? I think I have a lot of questions on hyperphosphatemia. So I was just trying to think like, would that kind of like alleviate a little bit, can prevent the progression of cardiovascular mortality?
Well, I think that's a complicated question.
Okay.
I remember going to an ASN 10 years ago, maybe a little bit more. And an extremely self-confident cardiologist walked up to the dais and said that cardiovascular coronary artery calcification is the sole cause of excess cardiovascular morbidity in end-stage renal disease patients. Right? That's what they think in the cardiology. Some of these people think in the cardiology community, okay? Now, there's no doubt, okay, that control of phosphorus has its benefits, at least I think has its benefits, including mitigation of extramedullary calcification, okay? No doubt, okay? But whether that particular coronary artery calcification is truly pathogenic, I think, is still up in the air. We have lots and lots of patients who get CT scans now and have calcium scores. And, a lot of them are still alive. I think this kind of circles back to my thought about, you still have to treat the osteodystrophy, okay? It's still a vasculopathy. It's still going to cause harm to people. You have to treat the osteodystrophy, okay? And so I don't argue against the need to control hyperphosphatemia. What I'm saying is, would I go so far as this cardiologist that I saw 10, 15 years ago at ASN who puffed his chest out and got up to the dais and said all excess cardiovascular mortality is because of coronary artery calcification? I don't know if I'd go that far.
Perfect. Okay. Thank you so very much. Not only the presentation was excellent, but you made it in time, Joe. Thank you very much. This was really refreshing. I have to say that. Thank you, everyone. Thank you for being here. And thank you again, Dr. Tantravahi, for a wonderful presentation. I hope you all will have a great weekend. I assume the candidates will have some meeting with Dr. Ruchi after this session. Thanks again.
Thank you.
Thank you.
Thank you.
Bye.